Good morning, and thank you for joining us for the Sleep Health Caucus's first briefing on sleep health in the pandemic. We have four fantastic panelists followed by a brief Q&A. Please use the Q&A function of the Zoom chat for your questions, and we will answer it at the end of the hour. But first, we would like to hear from the chairs of the caucus, and first we will hear from Congressman Rodney Davis.
Well, thank you very much for having me. I just am proud to be able to be a co-chair of this very important caucus with my friend, Chairperson Zoe Lofgren. This is an issue Zoe and I have been willing to work together on. And in the midst of what most think in America is hyperpartisanship out here in Washington, D.C., many would be surprised. There's a lot of good bipartisan work that gets done on issues that are important to so many Americans. Sleep as to an issue that needs to be addressed in this country. We need to do a job of identifying what allows individuals who may be sleep deprived to be able to in their job. Perform sleep health should not just be relegated to professional athletes and Olympic athletes. We need to talk about what impact it has on the safety of our roads, on the safety and health of every individual experiencing problems. And these are the issues that I know our panelists are going to discuss today. I'm proud to partner with one of you also, and I look forward to working with you in the future once we all work together to identify what to help with. So thanks for having me. Thanks for allowing me to be a co-chair on this important issue. I look forward to, again, working with Zoe and everyone on this call and everyone watching.
Thank you, Congressman, and thank you for taking time out of your day. And now we'll hear a brief message from Congresswoman Zoe Lofgren.
I'm Congresswoman Zoe Lofgren, representing California's 19th District, and I'm one of the two co-chairs of the Congressional Sleep Health Caucus. Thank you for taking the time to join this briefing. I know all staffers have busy schedules. I was a congressional staffer myself years ago. Throughout the past 2 years, we've all been dealing with the unique challenges and added stress brought on by the COVID pandemic, and the necessity of good quality sleep is all too clear. The anxieties around employment, health risks, and uncertainties about what the future holds have undoubtedly impacted our sleep patterns and exacerbated sleep disorders. This should be a concern to those of us who care about public health. Insufficient sleep has been associated with hypertension, obesity, and even depression. However, the impacts of the pandemic have not been all bad as it relates to sleep health. With increased access to telehealth, many people are receiving the medical attention that they once lacked access to. And some reports have shown that students have experienced less sleep deprivation while learning from home. For some time, I've been particularly interested in how the effects of poor sleep health can be compounded for young adults and children, often leading to poor health outcomes and poor performance in school. We should be studying this at the federal level. That's one of the reasons why my colleague Rodney Davis and I established the bipartisan Congressional Sleep Health Caucus in the last Congress. We're aiming to draw attention to sleep research and the importance of following sound science. I don't want to take up too much of your time today so that you can hear from the experts. I appreciate that each of them took the time to join us and to offer their perspectives. The American Academy of Sleep Medicine, the Alliance of Sleep Partners, the Sleep Research Society, and Dr. Yuen have helped further educate me and my staff on the topic, so you will be gaining valuable insights. Thank you again for your time and interest in sleep health.
And again, we'd like to thank both of the representatives for their leadership in making sleep a priority in Congress in our nation. And now we're going to hear from our first speaker, Dr. Indira Gruba Gabalutula. Indira, take the floor.
Thank you so much. I appreciate this opportunity to be here. And I just want to make sure everybody can hear me. Okay, So I'm going to be talking about sleep health for the public and how we can best promote it. I am a faculty member at the University of Pennsylvania. I am also director of the Sleep Medicine Fellowship Training Program at Penn, and also work at the VA hospitals taking care of veterans with sleep disorders. I'm currently chair of the ASM's COVID-19 task force. I'm going to be covering a lot. The first being telemedicine and sleep health. The second is physician burnout. The third topic is a nationwide recall that we're dealing with right now with respiratory devices used to treat a sleep disorder called sleep apnea, and also touch on sleep medicine research and education. So let's look at telemedicine. Before the pandemic, telemedicine was used very rarely, available mainly in rural areas, and it was limited mainly because of lack of payment. But there was evidence that it would be effective, it would increase access, and that there would be high rates of patient satisfaction with this. And then March 17th happened, and that was the day that CMS regulation came out that certain telehealth provisions would be now added, and the coverage for telehealth services expanded extremely rapidly so that return visits, new visits, patients in urban areas, rural areas could all receive coverage for services. The healthcare workforce also expanded quickly under this regulation so that cross-state licensure was honored. And so training for sleep residents, sleep medicine trainees could continue to get training across state lines. There was a clause on patients over paperwork so that burdensome paperwork requirements to get respiratory assist devices were temporarily suspended. And this concept of hospital without walls, where patients could be in their homes, they could be in a tent or in a parking lot and still get coverage for services. And what this led to was just an unprecedented transformation in the way sleep medicine healthcare was delivered. And literally it was a seismic shift. And I'm going to show you some data. And this is Medicare primary care visits that happen by telehealth. So before the regulation changed, 0.1% on the order of 15,000 beneficiaries per week were getting telehealth services. After the shift in regulation, 44%. And so there was a very rapid rise, as you can see, in before versus after. So over a 2,600% increase, amounting to close to 2 million beneficiaries per week. And this increase, the uptake was also in urban areas as well as rural areas. In fact, there was greater uptake in urban areas. And this is results from a survey that we distributed that originated in the University of Massachusetts, and it was sent to ASM members, and you can see here that 74% of respondents were using only fully virtual visits, and another 4% had no limitations on what type of visit they would offer. So literally the numbers flipped, where now the vast majority of patients were being seen with telemedicine and sleep in the sleep centers. And this didn't just happen in March and April, in the months immediately following the change in regulation, but continued through July to December. And this is our own data from Penn, looking at 2017, 18, 19, and 20. And the blue bars represent canceled visits. And you can see that the number of cancellations went down. The red bars show that the number of no-shows went down, and the number of completed visits went up. And this is through 2020, so July through December, compared to prior years. And AASM also released a pulse survey of memberships and found that telehealth implementation by far overtook all other measures that were implemented during the pandemic to help adapt. And it was listed as the #1 strategy that was employed, and it was more important than home sleep apnea testing expansion, infection control practices, changes in operations, patient education and communication, COVID testing before sleep studies were done in labs, financial assistance, and guidance issued by CDC or ASM. So this was a huge uptake. And this is, again, Medicare data showing that the middle blue bars represent usage in those aged 19 to 64, so kind of working age adults. And the bars on the left, the blue bars represent age 18 and younger. So in children, the uptake was a little bit less, and even less in those ages 65 and above, and those are the light blue bars. So what we also have data from CMS is that certain beneficiaries, they could have video visits or telephone plus video, but it looked like certain distinct groups of beneficiaries were receiving care through telephone only. And those are older adults, 75 or older, Hispanic, rural, and those who were covered under Medicare and Medicaid, which is a surrogate variable for socioeconomic status. And what you can see is that in these groups, the majority were receiving only audio visits. Now, audio visits are better than no visits at all, but perhaps this also represents a lack of access to either broadband or to smartphones and devices that would allow the video connection. So when you look at the damage footprint of the pandemic, there's morbidity and mortality in the first wave that comes largely due to the illness itself. And then there's the second wave that comes because of restriction of elective procedures. And that was seen quite a bit, because of canceled surgeries and canceled visits to make room for COVID patients in hospitals. And then a third wave from chronic conditions. So while the second wave is from urgent conditions like heart attacks and strokes, the third wave was chronic conditions like sleep disorders. And what we found is that with sleep medicine, by being able to offer telemedicine care, that we were able to limit some of this damage in the second and third waves. And all of these waves have profound influence on our patient populations. But in addition, we were able to take the things we learned in the clinical realm and expand it to education and to research, so that some research could be continued using the same telehealth platforms that we would be using for clinical care, and also for education, so that our sleep medicine fellows and trainees could continue to get their education, could keep pace. And our class, they all graduated on time with meeting the metrics for competency. So telehealth was profoundly valuable. And in fact, the rapid uptake led the Academy to issue updated guidance in May. And I urge you to look at this document. It offers many, many ways that we can make the existing telehealth platforms even better. And there are two bills that have already been proposed, one in the House and one in the Senate, and they have been introduced, and they are sitting there. They have been referred to committee, and that's where they are. And I urge you to look at these and find ways to make the telehealth permanent with the Telehealth Modernization Act. So moving forward, what is needed then is to continue to maintain this expanded access that we've created, that clearly so many people have benefited from. We need to expand even further to make this available to those vulnerable communities that I mentioned that are impaired in terms of socioeconomics or physical health or debility or age. And absolutely what had this work was that payment parity was maintained, regardless of whether the visits were conducted by phone, by video, or in person. And that was a crucial component in having this work. And continue to allow workforce expansion. It makes no sense for a patient who lives just a few miles across the state line who cannot continue to see their doctor by video if that's the doctor of their choice. So allowing interstate licensure to be honored as it has been is going to be an important component of having this work, and continue to put patients before paperwork. So the burdensome requirements for ongoing coverage of important therapies needs to be readdressed so that doctors can focus on doctoring and helping patients. So when we look at these waves of damage that happen with morbidity and mortality, we've focused on patients, but there's this other group, which is the physicians themselves and the healthcare workers themselves who've experienced psychic trauma, mental illness, economic injury, and definitely this huge epidemic of physician burnout that was there even before the pandemic, with estimates ranging from 45 to 55% of all physicians, 45 to 55% reporting some degree of burnout. And I want to talk about this because it is a major public health problem. And we published a statement with the American Academy of Sleep Medicine looking at the role of sleep in particular in contributing to burnout among America's physicians. And when we look at burnout itself, there is lots of literature looking at resident physicians or physicians in training and the fact that they work such long hours, and a body of literature emerged that showed that they were sleep deprived and that this was affecting patient safety. There were errors being made at work, that it impacted their learning. There was high rates of depression by the end of the first year of training, and definitely high levels of burnout. And that this burnout was not insignificant. It had effects on exam scores while they were in training. So it was clearly affecting learning, that there was regret about career choice and a reduction in resiliency. But what happens the day that these residents graduate? We have virtually zero data looking at that. And we know that attending physicians who graduated from training programs continue to have very high service needs. Our patients have gotten sicker. The volumes of patients that are coming through, especially in sleep medicines, continue to grow as the sleep disorders continue to receive more recognition. There are also cultural factors inside of medicine where sleep loss and operating under conditions of severe sleep deprivation are seen as signs of endurance. And definitely there's been a huge proliferation of technology in medicine with electronic medical records, remote access networks, telemedicine, and mobile health. We want healthcare to be convenient. We want to put it in the palm of our patients' hands. We want to provide health to the public, but it's also coming at a cost of increasing demands. The boundary between work and home is now lost, where demands can come from any portal at any time to physicians. And so what we need is what is happening then to their sleep. We need to look at the role of sleep in increasing burnout. How often are they sleep deprived? How often are physicians working extended hours into the night? How often are they working full night shifts and are completely misaligned with their circadian biology? What about biological factors and their role in sleep? Some physicians may be more vulnerable to sleep deprivation than others. We know that women and Black physicians experience burnout at much higher rates. And then what about background sleep disorders that have not been identified? We have virtually no data. What percent of doctors are having sleep apnea or sleep deprivation, insomnia that can lead to burnout? And then what is the impact of this burnout on the practice of medicine? How is it affecting patient safety, access to care? Burned out physicians are more likely to be absent or experience presenteeism, where they're there, but they're not as efficient or as productive. More errors, more do-overs. And what about the physician workforce itself? We know that as a result of burnout, more physicians are leaving and exiting the workforce before they complete. And many of them that are leaving are older and more experienced, and they're exactly the people that we don't want leaving. They're the ones who are going to train the next generation of leaders and practitioners. So it's really important that we address this problem. So the ASM position is that physician burnout is a significantly underappreciated public safety issue, that sleep loss has been overlooked, and that we need to really look at the roles of sleep disruption, sleep deprivation, and misalignment in circadian biology, and look at that role in physician well-being, physician burnout, and then look at, once you identify sleep disorders, that opens up an entire avenue of potential countermeasures, and then we can start looking at how effective would those be in addressing burnout. The next thing I want to talk about is this nationwide recall of respiratory devices. So on June 14th, people everywhere woke up to this press release from Phillips Respironics that dozens of positive airway pressure devices were suddenly recalled. And let me just explain what this is. What is a positive airway pressure device or PAP device, and what is sleep apnea? So under normal conditions, when we breathe, the blue arrows represent oxygen entering the nose and the mouth, past the throat and into the airway and down into the lungs, down the windpipe. What happens in some people when they sleep is that these muscles relax excessively and they fall together and they vibrate. So they have some snoring, and sometimes it closes all the way where there's no oxygen getting through, and that's called an apnea. When this happens, the brain has a sensor for this and releases a surge of adrenaline to pop those muscles open and restore airflow. And so this can happen as soon as airflow is restored, the person goes back to sleep, and it just keeps happening over and over. The cycle keeps repeating. So the next day they can be exhausted, they can have difficulty performing at work, and this is particularly dangerous for safety sensitive occupations like truck drivers, airplane pilots, bus drivers, school bus drivers, ambulance drivers, and many other safety sensitive occupations, but also even older people who may have gait instability. They could fall down or become forgetful, leave the stove on, make mistakes at work, and so, or not be present, have mood disorders. It's also very stressful on the heart. So the repeated surges of adrenaline followed with the low oxygen levels are stressful in terms of causing hypertension, heart disease, rhythm problems, heart failure, and on the brain causing memory loss, mood disorders, forgetfulness, even Alzheimer's and stroke have been linked to sleep apnea. So the number one first line therapy is something called continuous positive airway pressure. And that's this small device that blows air into the throat and it acts as a pneumatic splint, and it keeps this airway open so that oxygen can continue to get through, and the person can then sleep and get a break from all that adrenaline. And that this is an example of one of these devices. Now, we encourage patients that CPAP needs to be used during all sleep periods, including naps. And there's a modem built inside these machines that allows us to track data. Did they use it? Did it work? Is the mask leaking? And is there any apnea left? And it is really important that patients adhere to treatment. And in fact, adherence is a requirement for ongoing payment through CMS and through third-party payers. So what the recall is about is that deep inside this machine is a piece of foam that's based on polyester-based polyurethane foam. And this foam barrier can, over time, break down and can be inhaled, and the gases can come off of this, and there's volatile organic compounds that could potentially cause irritation of the nose and throat and the eyes, or cause asthma, or worse outcomes such as cancer have also been linked to this, and neurological problems. And this disintegration seems to be made worse by ozone-based cleaning machines, which the FDA stated should not be used. So the question then is, what should patients do? So Phillips issued this statement on June 14th saying that if you use one of the devices on the long list of affected devices, then they should take these actions. If they're using ventilators that are life-sustaining, and if you were to stop them, there would be immediate death, those patients should not stop, but call their doctor as soon as possible. And everybody else who's on these CPAP devices should stop using their devices immediately and consult with their doctors, and understand that these patients include those who are truck drivers, bus drivers, ambulance drivers, airline pilots, and all other safety sensitive occupations. Many of them would be in this category, told to stop immediately. And so multiple professional societies got together and issued guidance quickly over the ensuing days, encouraging patients not to immediately stop because it could have serious personal health and important public safety effects. So the scale of having to communicate, we believe over 4 million people are affected. At the VA alone, 600,000, and immediately they needed questions answered. They needed to have access to their doctors, and there were massive demands on a workforce that was already experiencing burnout. The notice was issued via news media, so that there was no preparation in advance for messaging and how do we come up with algorithms and care pathways for this large numbers of people that were affected. And we were operating now under a little bit of a black box in terms of when can individual patients expect to get their machine repaired or replaced, and what is the exact magnitude of some of these risks? What percentage risk is that, so that we can weigh that against the potential risk of immediate discontinuation of therapy. And there are serious supply chain challenges, so that we can't just immediately issue a non-recall device to all of the millions of patients who need one. And there are additional special risks in children who have smaller lungs. Their bodies and brains are still developing. And the FDA on July 22nd issued a statement that this was considered a class 1 recall, which is the most serious type of recall, which kind of compounded everyone's stress and anxiety over this. The American Thoracic Society did issue this statement that was just published regarding a response to this. And it put our patients in a difficult bind, because some of them may choose to continue using their machine because of the experts recommending that they do, in order to prevent some of the serious side effects of untreated sleep apnea. But then it put their decision directly at odds with what the manufacturer was recommending, which is immediate discontinuation. And then we have another group of people who followed the manufacturer advice and completely stopped using their machine. So now they are in a position of now losing coverage. So the AASM, along with other societies, did submit a letter to Durable Medical Equipment Medicare Advisory representatives, and to please reconsider the reimbursement rules that requiring patients to use a device that they believe may be harmful to them, and then refusing to pay, and not covering it could be pose undue risks and also stresses for our patients. There's also a requirement that devices have to be at least 5 years old before they can be covered, and that there are additional needs for retesting. So we ask that those rules be suspended and that patients continue to get coverage for their devices, even if they temporarily stop using them in the light of this recall. Some patients in the meantime are expending out-of-pocket costs in order to get these devices replaced, if they're able to get a hands on a device at all. And then let's look at sleep medicine research and education. There is data that that sleep duration is linked to the immune response, and that patients who sleep longer in the time right around the time of vaccination tend to have mount better antibody responses and better cellular response to vaccination. And there's also some evidence that if you time vaccination in the morning instead of in the afternoon, in men with hepatitis virus, that they produce a better response. We also know that shift workers are more likely to get more severe COVID-19. So there seems to be this relationship between sleep duration and also sleep timing with how we respond to vaccine or to infection. But we need a lot more data. What should we do then with people who are insomniac? Should we be medicating them? What about timing of vaccine for people who are night owls or shift workers? What about patients with sleep apnea? Should we be giving all of them screening tests to see if they have it and then treating them so that they'll do better with vaccination or with impending infection? And then the other thing to realize is that patients with COVID-19, many of them report difficulty sleeping or sleepiness during the day. And those with long COVID experience this condition of brain fog or fatigue. These are huge numbers of patients. And what we don't know is what is the role of sleep disorders in contributing to some of these symptoms in either acute or long COVID. And then we absolutely should be spending resources on evaluating disparities in healthcare and how those have been exacerbated in the era of telemedicine, and looking at our particularly vulnerable groups. We need to be addressing the issue of healthcare worker burnout and looking at research on the role of sleep and sleep disorders in contributing to this problem, and also in maintaining our workforce and in training and addressing the pipeline and bringing in new trainees that can continue to replace those that are lost. Now, how can policymakers make a difference? I urge you to please invest in telehealth expansion, make these changes permanent, maintain parity with in-person visits so that video, phone, and in-person visits are maintain pay parity. Fund research evaluating the role of sleep health in this huge epidemic of attending physician burnout. Continue payment for PAP devices and suspend the adherence and age of machine requirements in the time of this massive recall that our industry is dealing with. Fund research on sleep and immunity, sleep disorders, and COVID, long COVID. And also we need to expand the amount of training slots that we have so we can continue to bring new specialists and new talent into the field and ensure a pipeline so it's there for all of us as we continue to get older. Thank you so much for your attention and for having me here.
Thank you for that great presentation. Again, if you have any questions, please put them in the Q&A section or contact us after the briefing. Our next speaker is David Bishop, who is a sleep apnea patient and also part of the ASM Public Awareness Advisory Committee. David, thank you for joining us.
Thank you so much. Hello, my name is David Bishop, and I was diagnosed with sleep apnea 15 years ago. I have a number of family members with sleep apnea, one who has Parkinson's and the other who was diagnosed with a widowmaker. So I know the connection between health issues and sleep disorders is of particular interest to the overall health, especially to my entire family. I'm here as a patient member of the Public Awareness Advisory Committee of the Academy of Sleep Medicine, and I'd like to thank Representatives Lofgren and her staff, as well as Representative Davis and his staff, for leading the Sleep Caucus and convening this briefing on sleep and COVID-19. I like to spend my 15 minutes discussing a range of things from a patient perspective that include relearning that oxygen is essential, discussing why the Sleep Caucus is so important to patients, the diversity of sleep advocacy patient community, the pandemic and COVID-19 and the use of ventilators and BiPAPs, and the Phillips recall of the manufactured Cpaps. Next slide, please. I was diagnosed with severe sleep apnea in 2006, and my throat collapses 31 times an hour while I sleep. I suspect that I've had this condition all of my life. And in hindsight, I don't know how I could have taken something so simple like breathing or getting oxygen to my brain and organs for granted. The awakening so many times an hour, and the cumulative arousals and fluctuations in oxygen would go on to impact my body. One such impact was developing glaucoma in my right eye and losing some sight in my early 40s. I would also learn that untreated sleep apnea and the accompanying oxygen fluctuation and arousals sets off a host of reactions in our sympathetic nervous system that contribute to very serious illnesses. Sleep apnea has a social, physical, and emotional toll. I certainly felt the financial impact of sleep apnea because I was seeing more specialists and I've had to take more time off of work. I would later learn that sleep apnea has a myriad of serious health conditions associated. And my family saw me struggle with my mood for years, and once adequately treated, I felt some relief. We can't take for granted how disruptive sleep disorders can be to our lives. Next slide, please. Patients and the sleep profession need this very opportunity we are undertaking today. The opportunity to have partners in Congress and the presidency who will elevate sleep and understand that there is a tremendous social and economic impact. That's seen in undiagnosed sleep disorders, underdiagnosed sleep disorders, and sleep health disparities. According to HHS's Office of Disease Prevention and Health Promotion, which convened a sleep health work group that spans 7 federal agencies for Healthy People 2030, a quote from their website states, "Sleep deficiency is an epidemic among people with chronic diseases and low socioeconomic status." It goes on to state, in the US, 30 to 40% of adults and 40 to 70% of adolescents report sleep deficiencies every year. Public health and sleep medicine continue to work to get this message out that chronic sleep deficiency is linked to increased risk of many health issues. Something that stood out in this information is that sleep deficiency contributes to health disparities seen in minorities and women. The information goes on to say that women and minorities are also underdiagnosed and at a higher risk of common sleep disorders such as sleep apnea. Next slide, please. Now, there are many sleep advocacy patient organizations working hard to improve access to treatment, affordability of drugs, increasing federal funding for sleep research, improve regulation, as well as accelerated innovation. While I'm not here to speak for any specific organization, I'd like to list a few of the organizations out there. The Alliance for Sleep Apnea Partners, the American Sleep Apnea Association, the Circadian Sleep Disorders Network, the Hypersomnia Foundation, Project Sleep, the Restless Leg Syndrome Foundation, and Wake Up Narcolepsy. There are other sleep disorders like REM behavior disorder, which are lesser known, who are struggling to form an advocacy group that have needs just as important as the ones I listed. But many sleep disorder patient organizations share a common issue. Our disorders are grossly underdiagnosed. It may be years, if not decades, until we reach a sleep physician. Next slide, please. That translates to countless workplace accidents, especially among our transportation workers across the airline, trucking, and transit industries. There are instances of train operators with undiagnosed sleep apnea causing loss of life from an accident. Well, what about your first responders, our doctors, our judiciary? Would you want a surgeon with undiagnosed sleep apnea who's doing brain surgery on a loved one? How about our police officers whose judgment may be impaired by an undiagnosed sleep disorder? We as patients need Congress and President Biden to understand that poor sleep and underdiagnosed sleep disorders are harming our fellow citizens' mental health, affecting road safety, contributing to less productivity at work, and tremendously contributing to other major health issues. And the cost to both Centers for Medicaid and Medicare, as well as insurers, and more importantly, to individuals and families, it translates to money out of their monthly budget. it's also harming our children with early school start times. I know that Representative Lofgren has been a champion of changing this for quite a while, and I applaud California for passing a statewide law that requires later school start times in acknowledgement of the harm that early start times cause to student mental health and academic performance. Next slide. So we know poor sleep lowers our immune system. Deficient sleep, whether or not it's linked to narcolepsy, insomnia, hypersomnia, REM behavior disorder, or sleep apnea, is linked to increased risk of major health conditions. Those at greater risk of getting severely ill from COVID-19, according to the CDC, list various chronic health conditions, including heart disease, diabetes, and immunocompromised individuals. Since the beginning of the pandemic, those with some of these major health issues have been showing up in hospitals across the country with positive COVID tests. The potential connection to sleep deficiency and vulnerability to COVID-19 cannot be ignored. And it provides another reason why quality sleep is essential, as well as adequately diagnosing sleep disorders. Next slide, please. Hospitals across the world are using bilevel continuous positive airway machines for COVID response to supplement ventilator use. It's put the spotlight on this type of intervention. These are the same machines that people with sleep apnea use to keep their airways open at night. These machines were the focus of many news reports as an essential tool for our healthcare heroes. The American Sleep Apnea Association, in fact, has a program which provides Cpaps at a low cost to people who are in need. I know from talking with their executive director that they're out of Cpaps. Next slide. The recent recall by the CPAP manufacturer Phillips due to safety concerns about cancer-causing foam, combined with the use of Cpaps for COVID response, has created havoc for many patients. The lack of oversight by the FDA concerning the safety of those CPAP machines is an issue for patients. Some people have to stop using their machines or risk adverse health conditions from their airway closing nightly. Others are not able to stop using their machines. There are many people who are impacted by the recall, and our transportation workers have to make a choice between using a potentially unsafe CPAP and work, or discontinue use while waiting for a replacement from the manufacturer and miss work. According to the Federal Register, the Federal Motor Carrier Safety Administration's Medical Review Board is holding a meeting September 29th to discuss the FDA's voluntary recall of Phillips Cpaps. They're meeting to give recommendations on how to assist medical examiners and commercial motor vehicle drivers who use these Cpaps on identifying reliable sources of information concerning options for drivers with machines covered by the recall. So while this issue is specific to sleep apnea, there are many other issues regarding other sleep disorders which are just as pressing and important to the health of people all over this country. Next slide. So in closing, the impact of poor sleep, as well as underdiagnosed sleep disorders, must be elevated in our collective minds as key to our mental health, physical health, community safety, and economic well-being. Thank you for your time.
Thank you, David, for that great presentation. Next, we're going to hear from the Sleep Research Society and Dr. Janet Mullington. Dr. Mullington?
Thank you very much. I will just share my screen. So I am here gratefully to represent the Sleep Research Society. I a professor of neurology at the Beth Israel Deaconess Medical Center and Harvard Medical School. And I'm a member of the Sleep Research Society's advocacy task force, and I'm the liaison to the American Academy of Sleep Medicine task force and advocacy task force. And I'm going to talk about sleep facilitation of vaccine titer accrual. I just wanted to say the mission of the Sleep Research Society is to advance sleep and circadian science. And we are a scientific member organization, and we foster education as well as scientific investigation about sleep and circadian science. Some years ago, there was a joint consensus statement. This occurred actually as part of the American Academy of Sleep Medicine and Sleep Research Society's work to educate the public and provide provider information, education. This was part of a CDC partnership to provide education about sleep to the public. And we recognized that our field hadn't come together and done a really thorough investigation of review, of the existing literature on the amount of sleep that's actually needed to maintain health in adults. And so the two societies brought together a number of experts in the field to review the existing literature in a number of domains. And they reviewed literature and came together, discussed it, and had voting on the consensus coming from general health, cardiovascular health, metabolic health, mental health, immune function, human performance, cancer, pain, and all cause mortality. And the recognition of the research available showed that a minimum of 7 to 8 hours of sleep is required for the adult to maintain health. And this brings into stark contrast the actual number of people in the country getting those 7 or more hours of sleep. 1 in 3 adults in the United States does not get the 7 or more hours that's recommended. This is based on CDC surveillance data. And here you can see some of this CDC surveillance data on the left. And you can see here that in the range of almost 40 to 50%, the darkest counties here are indicated getting less than that recommended 7 hours of sleep. Over here on the right, you can see a CDC county level vaccination. This is just 1 dose of vaccination that was obtained by these residents by September 12th. And you can see here, there's almost a perfect storm in areas of the country where the citizens are not getting adequate sleep based on recommendations, and they are not yet vaccinated. So this is of great concern to many of us who are aware of the importance of vaccination for health and protection of COVID-19. So I just wanted to give a little bit of background before showing you some of the data, but when you receive a vaccination, you get a first exposure to the antigen, and you get an antibody response here. Neutralizing antibodies are increased, and you get buildup of immunoglobulins, and these help to protect you against infection. It takes time, weeks, for this antibody and memory cell system to develop, the memory B cells actually rapidly deploy more antibodies in the event of exposure to the virus, and the T cells also develop over time, and they will attack the infected cells. So together, this system is carefully orchestrated, and it involves a first exposure and a primary anti-response, and then secondary antibody responses. Research has shown hepatitis A vaccine studies, experimental studies by Lang and colleagues some time ago, showed that if you deprived somebody from sleeping following injection at time 0 here, and look 28 days later when you'd expect a nice antibody response to have developed, if you look at the blood for the presence of the hepatitis A vaccination, what you see is that it's much lower in those who had been kept awake following the night following the initial vaccination compared to those who were permitted to sleep. And this group did a subsequent study where they followed more frequently and conducted the vaccination and looked at the amount of sleep provided, sleep in the dark circles here, and sleep deprived the individuals after the initial vaccination, and followed them as well. So those who are kept awake are shown here in the open circles, and they achieved a much lower vaccination antigen titer. So hepatitis B has also been used in vaccination studies, and this is data from our Prather and colleagues published in the Journal of Sleep in 2012, and this is a classic study looking at 125 healthy volunteers aged 40 to 60, and men and women in this study, non-smokers, good health, naive to hepatitis B, and they followed these individuals with actigraphy, which is a watch kind of movement detecting wearable device. And they found that those who slept less than 6 hours were much, much less protected. And in fact, they were less protected in 6 months out compared to those who slept more than 7 hours per night. They were 11.5 times more likely to be unprotected compared to individuals who slept for more than 7 hours. So what does all this mean with regards to COVID-19? Well, we know that risks conferred by pre-existing sleep disorders such as obstructive sleep apnea are associated with approximately 8 times the risk for getting COVID in the first place. That's data from Maas et al. And in a review and meta-analysis of the data thus far, Haryanto and Kurniawan recently reviewed 21 studies with 54,000 plus patients, COVID-19 patients, and found poorer outcome, more severe disease, including higher rates of ICU admission, need for ventilation, and death in patients with pre-existing sleep apnea. And recently, though, Huang and colleagues found that CPAP adherence greatly lowered the risk, and the longer these patients used their CPAP, the better they fared. Recently, a group of investigators, Peng et al., published in Sleep this year, data based on a UK biobank cohort of over 500,000 participants. And these participants had been studied earlier between 2006 and 2010. And the data was existing there in the data bank so that when these patients subsequently developed COVID-19, they could look at the outcomes following infection. And they found that both moderate and significant poor sleep behaviors were associated with increased odds ratio of being hospitalized 7 days after testing positive. They found that long sleepers, so people who slept more than 10 hours or so, were at increased risk of hospitalization. Very often these individuals have predisposing comorbidities, but frequent daytime sleepiness was also associated with increased hospitalization and mortality. And having insomnia frequently was also associated with increased hospitalization and mortality. Late chronotype, or the tendency to go to bed later, showed an association that, although wasn't significant, was a trend. So in the Journal of Sleep Medicine, sleep problems during COVID-19 have been reviewed, and individuals, when they have COVID, almost 75% of them have sleep problems. Healthcare workers without COVID also have sleep problems due to some of the stress and burnout that we were discussing earlier. And the general population during this pandemic has also had an elevation in sleep problems. So if one has COVID, and one is hospitalized for COVID, the recovery can be difficult and prolonged. And this actually occurs even quite often in patients with mild or even asymptomatic COVID, where there is a prolongation or a recurrence of some symptoms. And this data by Davis et al. Characterizing long COVID in an international cohort looked at 7 months of their symptoms. And what they found is that symptoms that are occurring very early on in COVID are prevalent in those who have a long COVID or post-acute sequelae of COVID. These sleep-related symptoms are hallmarks of that long COVID as well. So the fatigue, other sleeping symptoms, insomnia, sleep apnea, and these are experienced, all of these sleep disturbances by almost about 80% of these patients. So in summary, sleep plays a regulatory role in adaptive immunity. Short sleep duration is associated with a dampened response to vaccination. And I think that improvements to sleep health of the nation may be an effective aid for helping to achieve vaccine protection more quickly. And I think public education is extremely important in making sure the public knows that getting adequate rest, and most importantly, around the vaccination, will help to proffer a better response, antibody development response. And I think that it's extremely important now more than ever to be supporting the sleep research, research around immunity and the importance of sleep, and also for the recovery. And I think that the NIH and other federal agencies are doing a great job and really need the support, as does the CDC, who's done a tremendous job in educating and tracking for the nation. Thank you very much for your attention.
Thank you for that great presentation, Dr. Mollington. And finally, we will hear from Dr. Kin Yun on student sleep health in the pandemic. Dr. Yun?
Thank you so much. It's really a perfect opportunity to piggyback the content of my talk. I'm so excited to be here with you today. And I am assistant professor at UCSF. I'm also adjunct at Stanford. The origin of this is actually through my work at the Public Safety Committee of the American Academy of Sleep Medicine. We were able to put out an editorial regarding the data that we had at the time of sleep of children. And the data showed that there were some children that were able to get a few more minutes of sleep as compared to other children that did not. And this is basically a follow-up to that article that was released in the Journal of Clinical Sleep Medicine in April this year. As Dr. Milliken had alluded to earlier, the consensus statement that was put out by the American Academy of Sleep Medicine in collaboration with others, such as the Sleep Research Society, stated that adults in general should get about 7 or more hours of sleep. Hopefully they get closer to 8 or 9. However, since the 1950s, late 1950s, through the 1990s, we actually, for middle-aged adults, are getting less, 4 hours less, as a matter of fact. And these are wearables that were tracking the sleep of both young adults and older adults, and repeatedly, maybe for young adults, they should be getting 9 hours. Instead, they're getting about 8. And so we are seeing some of the effects that were aforementioned in regarding decreased possibly immunity. And we know when we are sleep deprived that we just cannot recall some of the basic facts that we want to emphasize, perhaps during a presentation, or we have some issues with mood regulation. And the population that I will be presenting are school-age children, and as well as middle schoolers and high schoolers. And what we learn is that the evening type chronotype, again, Dr. Millington was talking about earlier, the later our sleep schedules are, the more likely we're going to be lacking sleep. And that increases our susceptibility towards obesity. The next series of slides are going to demonstrate some of those points. The recommended amount of sleep, again, this is a recommendation through the American Academy of Sleep Medicine. For school-age children, elementary school age should be about 9 to 12 hours. Remember those numbers because we'll be talking about those again. And for middle schoolers and high schoolers, roughly about 9 hours on average, but can vary from 8 to 10 per 24-hour cycle. Now, unfortunately, even before the pandemic, none of us and none of the kids are getting that much, right? And David Bishop has talked about the adult population, how we're lacking sleep in almost another pandemic right before this occurred. And 6 out of 10 middle schoolers and 7 out of 10 middle schoolers before the pandemic are not getting adequate sleep. And we also have learned through this cohort in Brazil that we're following live births through the first 4 years of life. And once the baby was born, they were coming back to annual visits and found amongst those that are getting less than 10 hours sleep in infanthood that they will become obese or overweight. And that's defined as over 85 percentile for overweight and over 95 percentile compared to their peers of body mass index at age 4. Now, we know also from other data that supported by Portuguese population, that of the older child, again, elementary school age kids, if they're getting less than 9 hours, mind you, again, this is going to be 10 to sometimes 12 hours. If they're getting less than 9 hours, they have 3 times the odds of their peers to be obese. So we are looking at potentially a lot of kids that are at risk, of becoming obese. This is the US data. We have data from 1970s on for children that are aged 2 to 5. You don't need to be a rocket scientist to see the tripling of the obesity rate at the current rate. Again, this is pre-pandemic, and I have worse news post-pandemic as well. For the teenagers, we are seeing quadrupling the number of teens who have become obese in the United States. And this is very alarming. And when we couple the teens or children who are later sleepers, this is based in Sweden, is also confirmed with the US population. So with the kids that are aged 2 to 6, if they are night owls, go to sleep later than 9 p.m., they took longer to fall asleep, and they are asleep for less than 85% of the time compared to the time that they spend in bed, so-called sleep efficiency numbers, they are much more likely to be overweight or obese. And therefore, are we creating another epidemic by not having kids having enough sleep? Well, during the pandemic, the reason that some kids got more sleep, and that's great, and those are kids, high schoolers, that were sleep deprived to begin with. So finally, when they are attending school virtually and they have less activities that they could participate in outside, they were able to catch up on their sleep, which they had done or attempt to do during the weekends prior to the pandemic. But unfortunately, more than half of the children and teens are experiencing sleep disturbances even when they are able to go to sleep. And almost half of the kids are not getting the sufficient amount regardless during the pandemic. Now, what about elementary school children? How are they being impacted? Well, one report stated that, well, no-brainer. They are more sedentary just because they are having more screen time, because very often they have restricted activities as well. And screen time, what's interesting is not the skyrocketing amount of screen time that they got after the pandemic. It is the ones that are having screen time after 8 p.m., the middle line has also increased over time. And they're eating more unhealthy foods. You could see the healthy food is relatively a small increase, but the unhealthy foods has increased since the onset of the pandemic. They are involving a less physical activity that will increase their heart rate at least 10 minutes less over time over this period that was being surveyed. But a little bit good news, some were able to sleep 17 minutes more. Again, these are elementary school kids per night. So 17 minutes, at least that's an advantage in terms of recovering their sleep. The bad news, however, is that they have shifted the entire sleep schedule by more than 2 hours. So prior to the onset of the pandemic, they may be going to sleep before 10 p.m. However, since the pandemic concurring with the summer months, they are going to sleep later than midnight. And that creates a problem in that they're not getting adequate sleep. Mental health is taking a toll. The number of teens that are reporting symptoms at moderate to severe depression is more than half. And again, majority of them having sleep problems. The best predictor is how lonely they feel, despite the fact that they are so involved in social media. Any exposure and continual exposure to social media actually increases a sense of loneliness and increases the chance of having mood disorders. This is probably no brainer because, again, on social media, typically life is grand. And amongst the young adults as well, those 18 and over, this is really disheartening. More than a quarter around the time the survey was conducted from April to June last year consider suicide. About 7% has some attempts. And this is really disheartening. This is something that we can do something about to help these youngsters. The vulnerable population are going to be the ones that are in the lower socioeconomic strata. And some of them, even teens or young adults, are helping out the family, and they may be essential workers. Amongst those that are more affected are the African American youths that are sleeping a whole hour less compared to their counterparts, be it white counterparts, Asian, or Latinx. So if you're sleeping an hour less per night, the cumulative loss is going to impact on mental and physical health. Other populations involved, including children, as well as teens that were diagnosed with attention deficit hyperactivity disorder. Those that have more screen time are more likely to go to bed later than 11 p.m. They slept less, again, no brainer. And the surprising part is that 1 in 5 to about a quarter of these individuals were able to get a little bit more sleep. But again, they are in the minority. And those that were having sleep disturbances have trouble going to sleep. They were concerned, they were anxious about sleep, they woke up more, they were having nightmares. And of course, when they don't sleep enough, they are sleepy the next day. And so my summary of this data is a mixed picture that children and teens had sleep loss before the pandemic. Now, since the pandemic, although some teens were able to get a little bit more sleep, less than an hour, but they were able to accumulate some. However, majority of the children and the adolescents are actually getting less sleep. And the major culprit is sedentary type activities and increasing screen time, which is increasing their sense of loneliness and isolation. And having less sleep is increasing the risk of children, even those 2 to 5 years old, of, I should rephrase, about 5 years and older, it's been found that they have gained the equivalent of 5 pounds during the pandemic. And therefore, we are increasing the risks of children and teens of having obesity and the resulting insulin resistance and the risk of having complications or being infected with COVID, because obesity is one of the risk factors in adulthood that we know of. The at-risk population are those who are Black and who are economically more challenged. And so we know that sleep is integral to our well-being. Not only does it help with mood regulation, it helps us learn, it helps us focus in school, it helps us with our physical activity, just not feeling tired when we have got enough rest. And we have heard from multiple speakers in terms of how sleep is very important in helping us fight off viruses and accumulate enough antibodies so that we can reap the benefit of vaccination. And therefore, I urge both Congress members, representatives, and interacting with the lay public and school districts and emphasizing how important it is for children not only to be allowed enough time to go to sleep, but they also should be given enough time to rest. Lastly, I had pointed out that during the pandemic, a lot of the sleep cycles for children, as well as particularly teenagers that have a slightly longer biological clock, that they have shifted to well after midnight as the time to bed, and therefore they are getting up later. Now that we do go back to school, for some school districts, there are hybrid models. There are some that continue to study from home virtually. For those that do have to show up at school in person or chose to do so, we really need to work with the educators and allowing these children and teens to slowly transition to an earlier clock, because we all go through this every single year when we go to daylight savings and we have to shift that 1 hour. As adults, we know how difficult it is. It's almost impossible for the teens to shift 2 or more hours and to be able to function in the early morning. Of course, start school later has been mentioned earlier as well, and we don't want to undo some of the gains that legislation that California was able to pass, because if we have kids going to bed later, waking up later, now we require that they go to school earlier, then they are losing sleep in essence. Lastly, we should identify sleep disorders that may break up the sleep, and I urge everyone to think about sleep hygiene, kind of like dental hygiene. You know, we think about brushing our teeth every single day. We should instill the concept that we should be aware of the quality, quantity of our sleep. Are we having interruptions in our sleep? What might the reasons be? Do we feel restored when we wake up in the morning? And so this is a continual conversation, and I'm very excited about the inaugural Sleep Health Caucus that's being established with the help of our Congresswoman Lofgren, as well as Congressman Davis. And then hopefully with the work and encouraging sleep research through our partners, SRS, and various organizations supporting patients, we can move forward and enlighten even more people regarding the importance of sleep in our overall health. And with that, I want to thank you for your attention.